Welcome to part 2 of my OB-GYN review series. We're picking up right from the end of that previous video. We are on question 15. In real life, this pace would be unacceptably slow. However, because I'm walking through this problem with you in great detail, and I'm also walking through each and every answer choice, this is a pace that I feel rather comfortable with. All right, with nothing to do, let's begin the next question. Which of the following additional screening visits are indicated for this pregnant patient, at today's 28-week gestational prenatal visit? All right, so a bunch of screening exams, prenatal screening question. 24-year-old had 28 weeks gestation, first pregnancy, active fetal movement, no vaginal bleeding, leakage of liquids or contractions, no chronic medical conditions, no prior surgery, no tobacco, alcohol, illegal drugs. Good. So it seems like reasonably healthy person. Chlamydia is positive. All right. This is at her first trimester visit. Everything else is negative. So the patient was treated with azithromycin, negative chlamydia testing a month later. So that's good. Blood pressure is okay. BMI is high. Fundal height is 28. Fetal heart tones 130. 1 hour glucose challenge. Complete blood tests. Chlamydia tests are all ordered. Which of the additional following screening exams are indicated? All right, so this is at a 28-week gestation, right at the end of the second trimester. At this visit, we typically are done with most genetic screens. However, we do keep on performing some imaging tests just to look at how well the baby's doing. You can see that we have already assessed the fetal heart tones here. Cervical vaginal fetal fibronectin. This is a test that's used to that's used to analyze leakage of fluid, see how close the patient is to giving birth. There's no leakage of fluid here, so we would not do this test. Group B streptococcus rectovaginal culture. This is a test that's typically done at around 36 weeks or so. Um, it's not something that I feel like she needs to get done right now. RPR assay. She's already had a negative test before. I really don't think it's necessary to do this again. Um, I'm going to be leaning towards no on this one. Ultrasound for cervical length. A short cervix could definitely cause premature birth. Is a pretty significant risk factor for prematurity. However, I don't think this is a test that's routinely done. It's usually done for the workup of premature birth. I really don't know what the answer is here. It seems like all of these are not ideal choices. Hmm. Um, the only one that seems to reveal additional information. I'm just gonna say ultrasound length, ultrasound for cervical length for this one. I'm kind of between B and D. It could also be C. Yeah. This was a tough one. So the correct answer choice was also another RPR for syphilis. So I guess this is the beginning of the third trimester now, and you need to repeat just about every single STI test. I guess it makes sense. It's been a while since the previous tests. She might have contracted something during that period. She does have a history of UTI, so it makes sense that she would be at higher risk. Group B strep was the wrong answer for the reason I said earlier. That's collected at 36 to 38 weeks. Ultrasound for cervical length is typically used to assess for the risk of premature delivery in patients with preterm contractions or prior preterm deliveries. Yeah, so neither of those tests are routine. I got this wrong because I underestimated the risk of getting another STI, particularly in a patient who has a history of STI. Just got back from swimming, so my ears are a bit clogged. Next question. This is a management question in addition to antibiotics, which should be given. Another, sounds like it's a mother who's giving birth. 34-year-old, 26 weeks gestation, intermittent leakage of fluids. All right, so this is PPROM, premature rupture of membranes, and she is definitely preterm at 26 weeks. This is pretty severely preterm too, so you'd want to try to delay birth as much as you can. No vaginal bleeding, no contractions. Previous was complicated by PPROM at 29 weeks. She delivered at 34 weeks after inpatient management with corticosteroids and latency antibiotics. Okay. Oh, she's pretty febrile, 39.4. Definitely high suspicion for choreo. Fetal heart rate is 170 per minute. Yeah, my suspicion for choreo is super high. The amniotic fluid is getting infected. Purulent amniotic fluid. Yeah, there we go. Yeah, so she definitely needs immediate antibiotics. And even though this will be a preterm birth at only 26 weeks, when there is choreo, you have only two options. You pretty much have to deliver immediately. You would immediately induce labor. Maybe give some corticosteroids during that process, but it's not going to help much. Fibronectin and low maturity testing, no, because it's not going to be, you already know it's not going to be mature. You wouldn't manage expectantly. If she goes home, this is not going to work. She's going to become septic. Outpatient monitoring, bed rest, no. You need to act very quickly. You need to say when there's choreo, the risk of the fetus is way too high. You wouldn't do amnio infusion either. Amniotic fluid index is fine. Yeah, so immediate induction, even though she's only at 26 weeks. All right, that is the right answer. Intraamniotic fluid infection is a complication of preterm premature rupture of membranes due to the increased risk of maternal morbidity and mortality. Patients with intraamniotic infection require therapeutic antibiotics and immediate delivery, regardless of gestational age. 26 weeks, she might survive. Next question. Which of the following is more likely the cause of this patient's symptoms? All right, so seems like we have a number of endocrine conditions here. This is a 29-year-old with type 1 diabetes coming to the office with increased fatigue and irritability. Symptoms started 2 weeks after patient developed a URI. Cough and rhinorrhea improved, but she continues to have fatigue and weight loss. All right, each patient had an uncomplicated delivery 2 months ago, 2 months postpartum. She's formula feeding. Blood pressure is high. Pulse is not tachycardic, but high. BMI is high, well, borderline, I guess. However, she's losing weight, all right? Thyroid is symmetrically enlarged and non-tender. Cardiopulmonary exams unremarkable. So yeah, like I suspected, there's a thyroid problem. Hand tremor is present, so she's definitely hyperthyroid, hypertensive, heart rate's fast, she's losing weight. TSH, however, is actually normal with high free T3 and T4 levels. Low uptake on a radioactive iodine uptake scan. All right. So what's happening here is that the thyroid has actually been destroyed already by the thyroid has already been destroyed, and those and the destroyed thyroid cells ended up releasing all the thyroid that they've been kind of storing up, or at least are starting to produce. As a result of this, the body experiences an immediate surge of T4, which gets converted into T3. And radioactive iodine uptake is low because the thyroid has been destroyed. It's not actually taking in iodine anymore to create new thyroid hormones. Cause is not exogenous thyroid ingestion. TSH would be, you'd see the same findings, but I guess I can't really, the labs will be the same, I guess. But thyroid wouldn't be symmetrically enlarged and untender. Graves' disease, no, that's yeah, again, the thyroid's going to be enlarged, but you'd see elevated radioactive iodine uptake. Euthyroid 6 syndrome, no, this is not that. TSH is normal in that. Postpartum thyroiditis, maybe. Subacute granulomatous thyroiditis. So one of these is painful, and I think it's subacute granulomatous thyroiditis, whereas de Rydell's thyroiditis is painless. In this case, there's no pain. So I'm going to go with answer choice delta, postpartum thyroiditis. And I think the mechanism behind both of these is the same. The immune system just destroys the thyroid. Let me see if I'm right about that. Yes. All right, so the answer choice is indeed postpartum thyroiditis. Postpartum thyroiditis is a painless autoimmune thyroiditis which can occur within 12 months of delivery. Patients have a variable disease course, maybe hyperthyroid only, hypothyroid only, or hyperthyroid then hypothyroid. Diagnosis is confirmed with a positive thyroid peroxidase antibody assay. All right. Most patients actually eventually return to a euthyroid state and do not require treatment. All right. Compared to de Quervain thyroiditis, aka subacute granulomatous thyroiditis, the patients in subacute granulomatous thyroiditis tend to have a lot of pain and a very tender thyroid, and we're not seeing that here. Next question. So this is a pathology question that's about the female reproductive system. 53-year-old G2P2 comes to the office with right-sided pelvic pain that has worsened over 3 months. Immediately, I'm thinking, is this GI or GU? She's been experiencing bloating and hot flashes since her last menopause period a year ago. She's been sexually active with a new partner, is not using condoms, okay? She was treated with chlamydia in her 40s. No other medical problems, bilateral tubal ligation after C-section of second child, smokes 10 cigarettes daily, drinks alcohol. All right, so not a healthy person, but nothing is sticking out at me. Leukocyte count is okay. Beta HCG is okay. There's this 7-centimeter right ovarian mass with solid components, thick septations, and a moderate amount of peritoneal fluid. Yeah, so this is some type of ovarian cancer. I'm not exactly sure which kind it would be, but let's keep on going. It could be epithelial, which can definitely cause a lot of peritoneal fluid. It could be teratoma, especially with actually, this is only solid. Teratomas would have a lot of different components. Could also just be like a cystic adenoma or one of those more benign conditions as well. It's not going to be abnormal proliferation of the tubal epithelium. I don't even know what this is. Ascending infection from the cervix. No signs of infection. Tubal epithelium just doesn't really make sense here for me. Not aware of what disease that is. Ectopic implantation. This is endometriosis. Endometriosis, you can see cysts definitely. However, you would not see these thick septations, and you'd see other symptoms such as actually, I don't know if you can get endometriosis after your Well, when she was having periods, at least she'd have some other symptoms. Excessive growth of well-differentiated ectodermal cells. I don't know what to make of this one. Ectoderm, that's skin, nervous system. I don't think the reproductive system is going to be ectoderm. I'm pretty sure that's mesoderm. I don't think it's delta. Echo obstruction from fluid accumulation in the fallopian tube. You could get that. Yeah, I think you could definitely get some fluid accumulation in the fallopian tube because the ovarian mass is definitely going to be kind of compressing that fallopian tube, leading towards echo. Let me just go through this one more time. Abnormal proliferation of tubal epithelium. Don't know whether this could be the right answer, I guess. It's not an infection. It's not endometriosis. Yeah, this part about well-differentiated ectodermal cells. What could they be referring to? I guess with the vagina, it might be ectoderm, but anything that's more interior of that, it's going to be mesoderm or endoderm. Yeah, I'm going to go with echo. And I'm wrong. So the answer choice was alpha, abnormal proliferation of tubal epithelium. Yeah, I suspected epithelial ovarian carcinoma. I didn't know that, I don't know how the tubal epithelium comes into play here, but let's take a look. Epithelial ovarian carcinoma refers to a malignancy involving the ovary, fallopian tube, and peritoneum. Oh, that explains it. So this ovarian, even though it's called epithelial ovarian cancer, it involves a lot more than just the ovary. It kind of progresses, not metastasizes, but just kind of progresses to the fallopian tube and peritoneum as well. So in that case, yeah, I guess that makes sense. The cancer has already spread to the fallopian tube. So yeah, so I think I actually got the diagnosis right. I just didn't recognize this answer choice. Ovarian cancer can present as an adnexal mass with pelvic pain and bloating due to abnormal proliferation of ovarian or tubal epithelium or peritoneum. Ultrasound features suggesting malignancy are solid mass with thick septations and the presence of ascites. All right, so I got this wrong because I didn't realize epithelial ovarian carcinoma could also involve the fallopian tube, and the way that this choice was worded made it seem like the fallopian tube was actually the primary site of the tumor. It is not, but I'll just keep that in mind. It doesn't always have to refer to the primary site of the tumor. Got the diagnosis, but the wrong answer. Almost halfway there. All right, this is a labor curve question. It's pretty much why this thing is delayed. 34-year-old G5P4, 39 weeks gestation, contractions and spontaneous rupture of membranes. Pregnancy has been uncomplicated. BMI is 33. She gained weight appropriately. Yeah, I think so. For her, it'd be 0.25 kilos for 40. Yeah, so okay. 2 weeks, 2 hours after admission, she gets neuraxial anesthesia, no longer feels pain. After the epidural, she has variable deceleration, so intrauterine catheter is placed. The variable decelerations resolve with amniotic infusion. Her labor continues. All right, so 6 is kind of the cutoff between the active and the latent phase, and as you can see here on this curve, it took her 4 hours to progress 1 centimeter. That's too slow in the active phase. You want at least I think you want 2 centimeters an hour ideally. So this has nothing to do with the cervix is not really even open yet. She's having contractions, but that's not really that's not really like the main point here. Main point is that her cervix is not dilating fast enough. Mostly the cause of that's going to be oh right, I forgot this part. Fetal heart rate's good. 200 Montevideo units over 10 minutes. So this means that she's contracting well. Anything less than this, and you could say that she's not contracting well. Her strength is okay. Fetal head is not involved in this particular instance because that'd be a rest of descent. We're not talking about descent here. Fetal gestational age, no, that's not related. Maternal parity, she'd be dilating faster actually because she has done this before. So neuroaxial anesthesia can interfere with dilation. I'm going to go with echo, and I'm wrong. Most people were wrong. Most people chose neuroaxial anesthesia when it should have been cephalopelvic disproportion. So the head is too big. Huh. Yeah, so this is active phase protraction is commonly caused by cephalopelvic disproportion, in which the fetal head is too large to fit through the maternal pelvis. Oh, this baby was sunny side up. I missed this. Okay. All right, active phase protraction is less than 1 centimeter dilation in 2 hours due to the active phase of labor. Yeah, so you'd at least see, so you want to see at least like 1 centimeter in 2 hours, ideally 2 centimeters in 1 hour. Cephalopelvic disproportion is the fetal head is too large to fit through the pelvis, common cause of labor protraction. Let me pull up my document here, my sketchy, and reference that. All right, so it seems like I've actually lost a file. That really sucks. All right. Well, I guess that's that. Yeah, this is a hard one. I really don't think I'm going to remember this, quite frankly. It doesn't really make sense to me, and the answer choice doesn't explain it well. But I guess if there's protracted active phase of labor, think about cephalopelvic disproportion. Neuraxial anesthesia can lengthen the second stage of labor, which is 10 centimeters cervical dilation until fetal delivery, but not the first stage. All right, this is counterintuitive to me. I'll just skip this for now. All right, we're halfway there. This is about the symptoms. I'm going to go a little bit faster. All right, this is a UWorld question. So 54-year-old has evaluation of leakage, involuntary urine dribbling. She also has UTI symptoms for the past week. All right, has 3 UTIs declared with antibiotics. So the 3 UTIs are kind of suspicious here. It makes me think that maybe she has some problem with her urethra being too short or some kind of a hole in her urethra. Does not leak urine with Valsalva. The vagina is dry and atrophic. This can actually interfere with urination. I'm not exactly sure why. I'm guessing it just screws up the entire area. 2 centimeter tender anterior vaginal mass is palpable and causes expression of bloody discharge at the urethral meatus. So this makes me think there's some kind of a cyst that's forming in the urethra. Postvoid residual is actually fine, so it's not obstructing. It's just kind of causing bad symptoms. I don't think there's an abnormal tract per se between the bladder and vagina. That's a fistula, and that's not what we see here. Acute infection. I think she has an acute infection, but I don't think that's really causing this issue that's been going on for 2 years. I think there is hypermobility of the urethra and bladder neck, uh, but we would see, but her Valsalva is actually fine, so there's not enough hypermobility to explain why she's having this problem with incontinence. The choosers are fine. This false residual is fine. So this is because of localized outpouching of urethral mucosa. So I'm going to go with echo. This is outpouching and it's causing symptoms. All right, good. So I got the right answer. And urethral diverticulum is an abnormally localized outpouching of the urethral mucosa that can collect urine, resulting in inflammation of the surrounding tissue. Patients often exhibit dysuria, post-void dribbling, dyspareunia, and a tender anterior vaginal wall mass that expresses a purulent or bloody urethral discharge. All right, so pretty much the same way I explained it. Next, this is about levothyroxine during pregnancy. A 26-year-old with history of hypothyroidism is pregnant. She wants to become pregnant soon. She has a history of hypothyroidism for several years, has been on levothyroxine. TSH was good, mild fatigue, but asymptomatic. How should this patient manage pregnancy while hypothyroid? This is an interesting question. So during pregnancy, their level of hormone binding globulins end up increasing. The patient also has far more volume in general. As a result of that, a lot more free T4 is going to be bound. Active T4 is going to active T4, T3 are going to be the same. You want to give increased doses of levothyroxine because more of it's going to be bound and therefore inactive. You wouldn't continue the current dose. You need to increase. You wouldn't decrease the dose. You wouldn't change. I don't even know what this medication is. Leothyronine. I don't know why you wouldn't start a new medication either. You would actually increase the dose prior to pregnancy, I believe, since a lot of the changes can occur before she, in the very early phases of pregnancy. I guess in real life, it could increase the levothyroxine dose when she becomes pregnant as well, but I think it just increases the risk of her getting hypothyroid because she doesn't know she's pregnant or the pregnancy test is inaccurate. So I'm going to go with Charlie. All right, no, so I thought I remembered this question, but I was actually wrong. So you would actually increase the levothyroxine dose when the patient becomes pregnant and not prior to pregnancy. I remembered it as the opposite way around. All right, so I guess what this means is that you do not need to increase it right now since her dose is okay and her TSH is fine. Oh, I see. So wishes to be pregnant soon. So I guess it means like she's not actively trying to conceive and having sex. Because if she is trying to do that, then I think you start the levothyroxine immediately. I got confused by the wording of this question. I guess if she's not pregnant but wishes to become pregnant soon, it's okay to wait. However, if it says that she is actively trying to conceive, then you have to increase the levothyroxine immediately. All right, this is an anti-D immunoglobulin question regarding blood types and Rh factors, differences between the mother and the child. Mother is O negative, father is O positive, so you need some kind of prophylaxis. First pregnancy had abruption, so she received the standard dose of anti-D globulin at 28 weeks during her first pregnancy and again day 1 postpartum. Patient has no medical problems, no history of transfusions. Anti-D antibody titer is currently 1 to 32. This is too high. I believe a 1 to 18 is acceptable. 1 to 32 is high. Yeah, so we're trying to figure out, even though she got the antibody titer, she got the RhoGAM, she still got anti-D antibodies. So I think she definitely got an inadequate dose after her first delivery since she got the abruption, which means she was exposed to a huge amount of fetal blood. Normally, if she had not abrupted, I think this regimen of Rogam would have been fine. You don't give anti-D betas wrong. No anti-D globulin prophylaxis between the pregnancies. I don't think this is something you routinely give. Premature administration of anti-D globulin for first pregnancy. I don't think so. I think you do typically give it the day after the baby's out. Undisclosed new paternity wouldn't interfere with anything. So I guess it's A. Right? And I'm right. Great. So anti-D immune globulin should be administered to any RD negative mother who delivers her RHD positive baby. Standard dose is adequate at 28 weeks gestation. After delivery procedures, the KB test is used to determine whether a higher dose is needed due to increased risk of fetal blood cells entering maternal circulation. Yeah, so perfect. We use that to dose Rogam. Question 23, management question regarding hand complaints. This is a 28-year-old at 30 weeks gestation coming in with burning pain in her right hand. It's intermittent, mainly over the first, second, and third digits. All right, so this is in the median distribution. So that is going to be a pretty classic case of carpal tunnel. This can happen in pregnant women because their palms get swollen, or they just get more swollen in general during pregnancy. Fluid can kind of block off the carpal tunnel area. Treatment is pretty much the same. You just end up you just do a splint. That's the first line. I guess you could wait until after delivery if she just decides to. She just decides that she can bear with it, but wrist splinting is kind of like a simple procedure. So I guess I just go with echo. You wouldn't inject glucocorticoids since that wouldn't help with carpal tunnel, wouldn't reduce swelling, decompression. Maybe in very severe cases you would, but it's really doesn't feel necessary. Acetaminophen. No, this is kind of a neuropathy. Acetaminophen wouldn't help with that. All right, I got it right. Carpal tunnel syndrome is common in pregnancy. Most patients with mild symptoms respond to nocturnal wrist splinting, which holds the wrist in a neutral position and prevents excessive flexion during sleep. In most cases, symptoms resolve spontaneously after childbirth. All right, good. Next, we have a question about the management of tuberculosis. This is a 22-year-old woman at 19 weeks gestation who immigrated from India 3 weeks ago, had a positive interferon gamma release assay. So this is a quantiferon test, which means she has tuberculosis. It's not just a vaccination thing. Her HIV screening is normal, which is the best step. All right. So for a case like this, typically you would get a chest x-ray to see if she has either latent tuberculosis or active tuberculosis. I think you should be able to just do a chest x-ray on her since you're imaging the chest. I wouldn't repeat the interferon gamma because there's no point. Tuberculosis testing, no. She might probably have already gotten the BCG vaccine. You wouldn't give prophylaxis now. That means like you're preventing things, and you don't know if this is active or inactive, and so therefore you don't really know whether to treat for active or latent. The regimens are different, so I probably obtain a chest X-ray. All right, and that's right. Pregnant women should be evaluated for TB using the same diagnostic approach as non-pregnant patients. A positive tuberculin skin test or interferon gamma release assay should be followed with chest X-ray to differentiate latent infection versus active disease. So perfect. I was right on. All right. Next, we have a obstetric pathology question asking us to diagnose a condition in which a 32-year-old at 21 weeks gestation is having increased discharge. Discharge was initially clear a week ago, turned bloody today, no pain. BMI is 19, so kind of low. Fundal height is 19, that's appropriate. Fetal heart rate 155, also appropriate. Speculum exam shows scant blood and discharge. A bulging bag with fetal parts is protruding through the cervix, which is dilated 4 centimeters. This is an incomplete abortion. Microscopy of the vaginal discharge, so multiple squamous cells and a few leukocytes. Nitrogen testing is negative. That's kind of interesting because normally this would be positive if this was amniotic fluid. Regardless, though, yeah, this is incomplete abortion. There's fetal parts protruding through. Abruption, no, there's no bleeding per se. This would be sudden blood loss and pain. You'd see all that. Cervical insufficiency doesn't usually happen until later. And you see not premature in labor. She's not having contractions, not PPROM. Yeah, since nitrogen is negative, so we know that. Oh, I see. So her bag is actually still intact. That's why the bag is bulging through, but so the membranes are not even ruptured. Yeah, this is an incomplete abortion. Nope, it is not. So apparently it is cervical insufficiency. Painless cervical dilatation. This patient has cervical insufficiency, structural weakness of the cervix causing spontaneous painless cervical dilation, potent second trimester loss. It is not an incomplete abortion because that is defined as less than 20 weeks. So I guess I got the cutoff wrong. I thought the cutoff was 21. Incomplete abortion is typically painful due to uterine cramping. All right. So I guess cervical insufficiency, I got it wrong because I got the cutoff between abortion versus cervical insufficiency incorrect. Cervical insufficiency is a structural weakness of the cervix that causes spontaneous, painless cervical dilation and potential second trimester pregnancy loss. Yeah, 21 weeks is second trimester. So I guess that's why I got it wrong because I thought second trimester is 14 to 28, but I got the timeline wrong. All right. Well, patient has mild symptoms compared to incomplete abortion, which is painful. So 2 points. One is the timeline. The cutoff is 20, not 21. Also, cervical insufficiency is painless. Incomplete abortion is painful. 26. This is a question about, I think, about workup for ovarian cancer. She has this is a management question. Seems like some gyne pathology. 34-year-old, routine exam, regular menses, sexually active, intermittent dull pelvic pain that started 2 weeks ago. Oh, I saw this question recently. But she pretty much feels fine. Vitals are fine. Exam shows a 4 centimeter non-tender right adnexal mass. I remember this question, so I'm going to flag it just so I generally understand it. Pelvic ultrasonography, just because whenever you have like an adnexal mass, it needs to be imaged. It's probably nothing, probably just her ovulating, but out of safety, we have to ultrasound it. Apheresis and OH periods are normal. You wouldn't do this. Reassurance and routine follow-up. No, like I said, you have to image. Continuous OCPs. No, her periods are fine. Repeat pelvic exam in 6 weeks. No, you have to work up. Epithelial ovarian cancer, suspicion's pretty low. You image first to see what it is. And especially in this age group, it's more likely to be germ cell. Yep, so answer choice is pelvic ultrasonography. All right, we have a psych question. 27-year-old postpartum psych, 27-year-old brought to her husband due to anxiety. Uncomplicated vaginal delivery, has been really nervous. Patient would watch the infant overnight. She expressed concerns about the patient weight, but surpassed his birth weight and was eating and doing well. Patient has continued to worry. Oh, vaginal delivery was only a week ago. For the past 2 days, sleeping poorly. Found the patient mixing protein powder and concerned patient was shaking. Patient knows my baby is sick, but the doctors won't tell me the truth. He's kind of paranoid. They're trying to hurt my baby. She's no psychiatric history. Vitals are normal. Tearful and exhausted. What is the most likely diagnosis? Uh, I don't know if she meets the criteria for psychosis. Definitely very paranoid. Postpartum psychosis is super dangerous. Let's go through the answer choices one by one. Acute stress. No, that'd be like things like getting constant flashbacks, dissociation. She's not having that. Adjustment disorder with anxiety. I mean, I guess so. This is, I guess, a triggering event. She would have some anxiety, yeah. So that's out of proportion. Some, I guess, maybe. Delusional disorder, no, that has been going on. That has been to be going on for 6 months. It's only been 1 week. OCD, no, again, that has to be going on for 3 weeks. This is, I forgot the exact timeline. Let me check actually. I think OCP is 3 weeks. All right. So yeah, I really don't know. I can't find the answer anywhere. Yeah, sorry, at least on my notes. It's not postpartum blues. Yeah, no, she's not having depression symptoms. Kind of between postpartum psychosis and adjustment disorder with anxiety. Uh, this seems like it's going beyond just anxiety. This is her being paranoid. So I'm gonna go with Foxtrot. She has delusions that doctors are not telling her the truth. If it was like Munchausen's by proxy, I feel like that'd be even more appropriate, but I'm going to go with postpartum psychosis. 73% of people got it right. Yeah, so it is postpartum psychosis, characterized by acute onset of delusions, good, hallucinations, and disorganized behavior. All right, within the first 2 weeks. Good. This question about a blood gases. What's causing this pregnant woman to have a abnormal blood gas results? She's this is a 28-year-old at 10 weeks gestation. She's very alkalotic, 7.49. PaCO2 is high. Wait. Yeah, normally PaCO2 will be low in a pregnant patient. And bicarb is very high. Bicarb's usually around 20, I believe. Yeah, bicarb 20s to 30s. This is 44. So yeah, she's having good old metabolic. This is metabolic alkalosis, actually, which you don't see very often. And respiration seems to be compensating. For this one, you can get metabolic alkalosis from mostly diuretic use and vomiting. This is 10 weeks, so she's probably vomiting a crap load. This is not asthma exacerbation. No, you used to be acidotic. Hyperemesis definitely could be. Normal phenomenon, no. PaCO2 will be low in normal phenomenon. Obesity, we don't know if she's obese or not. Also, she'd be acidotic. PE, no. You'd hyperventilate and PaCO2 would actually be low. Severe diarrhea, no diarrhea. Yeah, mud piles. That causes metabolic acidosis. 78% got it right. All right, so it is, yeah. Severe vomiting is a cause of metabolic alkalosis, which is characterized by elevated pH, elevated bicarb, and a compensatory elevation in PaCO2. Perfect. We were right on. All right, so this patient is coming in with a rash and is asking me for the diagnosis. This is a 24-year-old at 31 weeks gestation with a rash on her back. It spread despite the use of, first it began as a small spot a week ago, has spread. Kind of reminds me of rosacea, despite the use of topical cream, no prenatal care. Huh. The rash extends upon her trunk and extremities, including the palms of her hands and the soles of her feet. Lesions do not bleed, no excoriations. So I kind of think whenever there's rashes on the palms and feet, on the soles and feet, you have to think about syphilis. You could also get this in hand, foot, and mouth disease. Let's look at the answer choices. Intrahepatic cholestasis, no. You get jaundice, you wouldn't get these rashes. Pityriasis, rosacea, this is what I was talking about earlier. So maybe polymorphic eruption of pregnancy, you could get this mostly on the face, but it'd be kind of uncommon for this to get so extensive. Syphilis, yeah, definitely. Tinea versicolor, no. It just wouldn't spread so quickly like that. And you'd be itching. No excoriations. The patient has been scratching them. Makes me feel like it's less likely to be rosacea. I'm going to go with secondary syphilis on this one. Oh, only 35% got it right. Yeah. This doesn't look like a typical syphilis rash, but syphilis can present in so many different ways. Secondary syphilis causes a diffuse maculopapular rash. This doesn't even look maculopapular. It just looks macular, but along the thin cleavage lines of the trunk, Christmas tree pattern that extends to the extremities, including the palms and the soles. Yeah, so perfect. Yeah, pityriasis, yeah, wouldn't go to the palms or soles. I remember getting it. I've got it just about everywhere except for my palms, soles, face, and genitals. Next question. All right, this is about ABO antigens. So, in a pregnant patient, 20 weeks, no vaginal bleeding, mild nausea resolved. Patient's doing well. She's O positive. Her husband's AB positive. Patient is concerned about different blood groups and the risk of pregnancy complications. Which of the following is most appropriate response? So ABO antigens do elicit a IgG response, but for some reason they just don't tend to be much of a issue when it comes to deliveries. I really just still don't know the mechanism for it. Antibodies are yeah, they only have like I think they have really mild hemolytic disease. Uh, she's not tolerant to ABO antigens. Immune response is not depressed. Antibodies are hemolytic, and they express an IgG response. So I'm going to go with Charlie. ABO incompatibility. Then Charlie's the right answer. ABO incompatibility typically occurs between a mother with blood group O and an infant with A or B, which can cause mild hemolytic disease of the newborn. Affected infants are usually asymptomatic or have mild anemia, may develop neonatal jaundice responsive to phototherapy. All right, good. So, yeah, it doesn't actually really say why like RH IgGs are so dangerous. Oh, another thing that I kind of missed was that this is a primigravid woman, first pregnancy, but I thought that she wouldn't even have antibodies to A and B. However, it turns out that most people will just automatically have this from antigens that kind of look like A and B antigens. So she does have antibodies. And this makes sense when you think about it. Otherwise, type O people will be able to get blood transfusions from anyone. And that's not the case, as long as they've never received a transfusion before. Next, so yeah, I got this right. Should I mark it? No, I'm not going to mark it. All right, next. Diagnosis question. It seems like she has some kind of vulvar itching. Patient has 11-year-old girl, pruritus intermittently. Symptoms have gotten worse. Constant itching. She has not yet reached menarche. She has swim practice using the swim bathing suit. There's thin white skin with excoriations extending to the perianal area. Superior portions of the labia minora are here in at midline. All right, so this is pretty important here. Just this part, the excoriations could be anything. Could be some lichen simplex chronicus. Could be, but that's typically thickened. With yeah, when the labia minora is kind of adherent at the midline, it's usually a sign of estrogen deficiency. She doesn't have. Does she have candidiasis? Thin white skin? No, that doesn't sound like it. Condyloma. Yeah, you'd see. You'd see itching for sure, but she's not really any high other risk factors for candidiasis. She's not diabetic, doesn't use a lot of antibiotics. No, she doesn't have warts. It's not warts. Labial adhesions, maybe. Lichen sclerosis. Could be, yeah. And it's extending into the perianal area too. Strep dermatitis, no, you wouldn't see thin white skin. Vaginal foreign body, no, you'd see vaginal bodies. So, labial adhesions tend to occur in girls who are younger, like preschool age. This is 11 years old. So, just based off demographics, I'm going to say lichen sclerosis. All right, lichen sclerosis was the answer. 60% chose it. It's not labial adhesions because that affects girls younger than 2. Okay. So it was even more extreme than I thought. Like vulvar lichen sclerosis commonly presents in prepubertal girls with pruritus and thin white lesions of the vulva and perianal region. Treatment is with suprapotent topical corticosteroids. Perfect. Next question. This is a read question first. Which is the next step in management? Sounds like she needs an abortion of some kind. 28-year-old woman has a positive home pregnancy test, 5 weeks gestation, breastfeeding, breast tenderness, but no dysuria, first pregnancy. Oh, this transvaginal ultrasound shows a thickened endometrial stripe, but no intrauterine gestation or adnexal masses. So we don't know exactly where where the pregnancy is. So beta HCG levels are pretty persistently high and it's increasing. Undergoes diagnostic DNC. All right. So the next day, the beta HCG is continuing to climb. Yeah, she's going to need additional workup. It seems like we're not exactly sure where this pregnancy is, and we can be pretty sure at this point it's not even in the uterus. We give methotrexate for this one. That's just a medication you give for ectopics. Levonorgestrel. This won't do anything this early on. That only works in the third term. This also only works during the third term. Reassurance and observation only. No, you need to do something. Serum progesterone levels. No, that wouldn't tell you anything. All right, good. Pregnancy of unknown location, abnormally rising beta HCG level, ectopic pregnancy, or an abnormal non-viable intrauterine pregnancy. So perfect. Oh, levonorgestrel is actually Plan B. It's not actually associated with ectopic pregnancy management. So I guess I messed up there, but that feels loyal to me. I'll recognize this if it comes up in a contraception question. Patient, so yeah, educational objective, ectopic pregnancy can be diagnosed as persistent rise in beta HCG following DNC. Medical therapy use with methotrexate. Perfect. Next, another question about management. Pregnant patient, 22-year-old with 27-week gestation. She has leakage of fluid. In intermittent green tinge fluid, now regular painful contractions every 3 to 4 minutes. So she's in labor. No bleeding. GBS negative. Vitals look good. Fetal heart rate tracing. Let's take a look at this. So rate is good, around 130. She's having decelerations. These are VO chop. So these are all late decelerations. So there's some placental insufficiency here. Fetal heart rate pattern. Yeah, so exactly. So they realize that she is having placental insufficiency, and therefore they move her, they give her oxygen. This is exactly the type of stuff you would do in these circumstances. So that's good. However, she continues to have these issues. Sorry, 1 second. All right. What would you do in this situation? Amino infusion wouldn't help. This is not a cord compression issue. This is a placental issue. Biophysical profile also wouldn't really help you here. It's not going to show you any additional information. C-section, maybe. Yeah, I guess fetal heart rate's a bit unreassuring, so maybe C-section. Vacuum assisted vaginal delivery. I mean, she's not even fully dilated yet. We wouldn't do this. Oxytocin augmentation. Not really. I feel like this is one too slow, and also she's already she's already kind of dilated, so I feel like oxytocin augmentation wouldn't do much. Yeah, I go with C-section for this one. Oh, another thing I forgot to mention was that there was no variability in here. I forgot to even take a look at that. So this is a category 3 tracing. Yeah, in category 3 tracings, you need immediate C-sections. So yeah, so I got it right. Even though I kind of messed up the reasoning, if I realized it being a category 3 tracing, I would have selected C immediately. It was a bit more time consuming, but I got it right in the end. Next question. This is about the patient's presentation, a 19-year-old at 38 weeks gestation. Coming in with severe abdominal pain and bleeding. So this is a pathology question. Ultrasound at 8 weeks for vaginal spotting, but no prenatal care. She had an abruption before. All right, so that increases her risk of another abruption. Yeah, she's having severe pain, and bleeding. So this is another abruption, no doubt about it. She uses cocaine, which is also another risk factor for abruption. Yeah, so again, this is abruption. Just factors for abruption. Illegal substance use is going to be the biggest part of it. First trimester bleeding could be due to anything. It's not related. Interpregnancy interval. The other one was how long ago? 2.5 years ago. Yeah, that's long enough of interval. Age is not related. 19 is fine. Prior uterine surgery. I think this does increase your risk of previa, but not necessarily abruption. She's having pain, so this is not previa. This is definitely abruption, beta. Wait, what? This is a rupture. Oh, I missed an important part in the question stem. No contractions are palpated. Oh boy. This is another one I missed because I didn't read the question patiently enough. No contractions are palpated. She's not having contractions. Then she has a rupture. Contractions stop and rupture. So yeah, if I had known that, I'd say if I had known that she ruptured, prior uterine surgery would be the cause. I got it wrong because I didn't read the question carefully. All right, here's a management question for a patient who has history of genital herpes, otherwise pregnancy is uncomplicated, no active lesions. So what will you do at 36 weeks? Well, when patients have genital herpes, obviously they have active lesions. Do not let them deliver vaginally, do a C-section. But even if they have a history of genital herpes simplex, you have to give them suppressant therapy. Sounds kind of counterintuitive to me. I feel like the outbreaks are pretty rare, but you still have to give it. So you have to give suppressive therapy until delivery. Yeah, you don't schedule C-sections just for a history of that. You'd certainly initiate cyclic therapy if lesions develop, but you give it prophylactically as well. Yep. So with women with HSV receive antiviral prophylaxis from 36 weeks gestation until delivery. So I was right. All right. Management of a patient with lower abdominal pain, patient with sharp pain in the the left lower quadrant that radiates to the lower back, 16-year-old girl, nausea, vomiting. Vitals look good. I mean, she's, I guess, somewhat distressed, so tachycardic, but seems otherwise appropriate. Urine pregnancy test is negative. Ultrasound shows 5 centimeter left ovarian mass with normal ovarian arterial and venous blood flow. After the ultrasound, she has another episode of severe pain. On evaluation, she has pain and tenderness to palpation. So this is a pretty classic case of torsion, except for she's having intermittent pain. So this is like a partial torsion that's kind of torsing spontaneously in and out. Cause is going to be this ovarian mass. I think for these partial torsions, you have to treat it as if it's a complete torsion. You have to do surgery. And yeah, so this will be a diagnostic laparoscopy. I mean, this is diagnostic in the name, but you need laparoscopy to treat it. CT, again, right? Like the ultrasound just already shown you that. The CT is not going to show you anything else. And says outpatient follow up. No, this is torsion. You need to do something. Observation, serial exams, no torsion. You need to do something. Quantitative beta HCG. No, you already know that she has a negative pregnancy test, so there's no point in doing a quantitative test. Yep. So the answer is yeah, partial ovarian torsion. So you would treat with diagnostic. So you do a diagnostic laparoscopy. Partial ovarian torsion typically presents with intermittent self-resolving episodes of unilateral pelvic pain due to temporary ovarian vessel occlusion. Good. Next. Oh boy, fetal heart. This is a delivery curve question about the best next step. 32-year-old at 40 weeks gestation has S-prom, painful contractions. Pregnancy has been uncomplicated. She seems to be progressing okay, I guess. She's getting 1 cent dilating. She's in the active phase now, set 1 centimeters per 1 centimeter per hour, which is fine. Category 1 fetal heart rate tracing. Vitals look okay. And the baby seems to be descending fine. Yeah, she's only been inactive for 2 hours. She's slowly dilating. Yeah, we wouldn't do anything for her right now. We just keep on managing her expectantly. We wouldn't do a C-section. Why would we do that? No. Intrauterine pressure catheter. No, we're not really. I'm not super concerned about her contraction strength right now. Contractions every 2 to 3 minutes. That's good enough. If she doesn't progress, I might do this. Operative vaginal delivery. No, again, she's progressing fine. Oxytocin augmentation. I feel like everyone in my hospital gets this no matter what, but you don't technically need it. Yeah, so this is normal progression of labor. It's 1 centimeters per hour, 1 centimeter every 2 hours is kind of like the limit. And the first, this is just talking about the stages of labor, latent phase 0 to 6, and the active is 6 to 10. Normal labor progression, the active phase is 1 centimeter or more every 2 hours. So, yeah, she's doing well. Next, it's a GBS question. How would we give GBS prophylaxis? 32-year-old, 37 weeks gestation, has contractions and fluid leakage. Prenatal care until 20 weeks, but has not had an appointment since then, so she has not gotten tested for GBS. Oh, her infant spent 3 weeks in the neonatal ICU for early onset sepsis, so that means that she had GBS. This previous infant had GBS. Once one of your infants had GBS, you're kind of presumed had GBS sepsis. You're kind of presumed to have always have it. So we would definitely give prophylaxis since she had a neonatal sepsis in her prior pregnancy. Her temperature and white count are fine. I mean, leukocyte count is high, but I don't think you would give anything for that. Did she have intraamniotic infection? Yeah, she did, but GBS doesn't cause amniotic infections. Recurrent fetal gestational age? No, that's not related. Time from rupture of membranes? We don't really know. It's like 8 hours. That again, GBS is not really like relevant to that. Yep. So I got it right. Vertical transmission of GBS during vaginal delivery causes early onset neonatal GBS infection. Patients with GBS bacteria in their current pregnancy or those who deliver prior infant with early onset GBS infection are high risk for transmission. Therefore, these patients require intrapartum antibiotic prophylaxis. Yeah, what's kind of interesting is that if they have GBS in their urine, they're also kind of considered to be at super high risk. Normally, you just swab the vagina, but I guess in their urine, you just kind of assume that they have it permanently. All right, almost at the finish line. So this is about a preventive healthcare in a 20-year-old. She is sexually active, lots of partners, using condoms. She has not received the HPV vaccination series and never had a pap test. Yeah, so she would want both of those things. Negative STD testing, vitals are good, no lesions. All right. So which of these is recommended in this patient? Yeah, so in younger patients, you actually don't test for HPV. You just don't do it. They clear HPV a lot of times, so you don't test for it. But you do get a pap smear though every 5 years in patients in their 20s. Yeah, you don't give HPV testing until they're 30. Reassurance, no, you wouldn't do that. You need to do pap testing, HPV vaccination alone. Again, I'm really not sure. I think like she might benefit still. I think this is usually given for teenagers, and past a certain point, you just don't give it anymore. Uh, Given how she's been already sexually active, I don't think you're gonna do HPV vaccination or even HPV testing for that matter. Yeah, I'd probably just do a pap test alone because cervical cancer is what you're ultimately concerned about. Never mind, I was wrong. So you do test, I'm sorry, so you administer the HPV vaccine, which is indicated for female patients and female male patients 11 to 26. So I got the age cutoff wrong. I thought the age cutoff was 17 or something, but no, it's 26. All right. But the vaccination might be given from 9 to 45. Geez, wow. Pap smears begins at age 21 in immunocompetent patients. So, all right, I guess when you're old enough to drink, you're old enough to get a pap smear. 20 is not young enough to drink, so you don't get any pap smears. I'm just going to think of a woman getting a bottle of beer as she's getting a pap smear from now on. So I got this question wrong because I got 2 ages wrong. I recommendations are to stop pap smears at 21 in immunocompetent patients, not 20. HPV vaccine is given through age 11 to 26, not 11 to 17. I don't know how to remember that. I'm 26 right now, so I guess I can imagine myself getting this vaccine. And you don't do HPV testing before you give it because previous or current HPV infection is not a contraindication. Vaccination provides protection against other HPV types. All right, good enough. Logical enough. This is about contraindications in a patient who is coming into OND for a severe headache at 27 weeks. 43-year-old. Wow. Okay. Her first pregnancy at 37 weeks. Dark spots in her vision. Oh, that's not good. Irregular, non-painful contractions. So this is Braxton Hicks. Patient takes pyridostigmine for myasthenia gravis. Okay, interesting. Rectovaginal was positive for GPS at 35 weeks. BP is grossly elevated. Severe features? Yep, definitely severe features. And seems like she is starting to dilate and get effaced, so I was wrong about that contractions part. She is going to deliver soon. Patient submitted for induction of labor due to preeclampsia with severe features, which of the following medications is contraindicated. Wow, so I didn't even have to really read any of that. It just, okay, well, whatever. So, which is contraindicated? Let's see. Would NSAIDs be contraindicated? No, I don't think NSAIDs would be. Pregnant people take NSAIDs all the sorry, acetaminophen. NSAIDs would be contraindicated because of that whole prostaglandin thing and how it can affect the baby's kidneys, but acetaminophen is fine. Hydralazine, you could give it. It's not contraindicated. It's not a great medication, but you can definitely give it in hypertensive patients. Hypertensive moms love nifedipine, hydralazine, uh, metoprolol, labetalol, and nifedipine are safe. Magnesium sulfate, no, you could definitely give this. Oxytocin, I feel like the myasthenia gravis thing is what's going to be pretty key here. I guess oxytocin can increase blood pressures too, so you wouldn't want that. Penicillin, no, penicillin is safe. Yeah, so this is like an acetylcholine pathway type of deal. Pyridostigmine, acetylcholinesterase inhibitor. Yeah, I don't know how oxytocin would directly tie into this. Maybe it is a severe features thing. Huh. Apparently, magnesium sulfate is contraindicated due to myasthenia gravis, as are a lot of other medications. That's more complicated than I thought. All right, myasthenia gravis is due to a neuromuscular disease in um, patients can continue to take acetylcholinesterase inhibitors during pregnancy. Patients with MG magnesium sulfate is contraindicated because it may trigger myasthenic crisis due to inhibition of acetylcholine release at the neuromuscular junction. Is it because magnesium can kind of push away the calcium and then like the calcium can't go in, which means that the acetylcholine can't go out? Maybe. Magnesium sulfate, commonly used in obstetrics, contraindicated in patients with MG because it may trigger a myasthenic crisis due to inhibition of acetylcholine release. Okay. I'd like to get a deeper answer, but I feel like I'm not going to get it. I feel like this is probably just that calcium thing I mentioned earlier. Let me do a little bit of research. All right, this doesn't really explain it later, so I guess we don't have to know that. Just know that it's contraindicated, I guess. Magnesium is contraindicated in MG. Hey, look, both of them are MG. MG is contraindicated in MG. That makes it easier to remember, although a bit ironic. All right, let's see how we did. So 68%, not great. Average 57, so we still beat the average by 11 points, and these were all questions that I've gotten wrong at some point. So not a bad result, but definitely not a good result either. OB-GYN is still a challenging topic for me, so I'll just keep on doing this video review series for you guys until I feel like I have really mastered the content. All right, this is Hans, and this wraps up our OB-GYN review series for today.